Good morning, everyone. How is everyone today? Great. So, first of all, I'd like to thank Congresswoman Kelly for the invitation. So, this is the front page of the magazine from the New York Times. I opened it just this past Sunday, and it reads, "Why are Black mothers and babies dying at more than double the rate of white mothers and babies? The answer has everything to do with the lived experience of being a Black woman in America." My name is Dr. Nicole Williams. I'm a board-certified gynecologist and TV news contributor on Fox, but a Chicago Fox, so it's not that bad. I was a newly minted OBGYN. On one of my first calls, I was summoned to the ER for a possible perimortem cesarean section. They brought her in. Already lifeless, I watched the ER doctors pummel her chest. In vain. I saw her eyes look right through me, void of anything. I listened and prayed for a baby's heartbeat, but there was nothing. I'd seen this in Rwanda, where I helped a woman who was bleeding to death survive. She was alive. But I was not in Rwanda. I was on the south side of Chicago. This was not supposed to happen here. So, we have exalted and wonderful guests here. We're going to address this topic in several ways. We're going to talk about the problem itself, defining it both statistically and its population significance. We're going to talk about what we are currently doing. And we are going to talk about what we could do. So we have Shanna Cox, who is the Associate Director of Science at the Division of Reproductive Health at the CDC, Ebony Marcel, Director of Midwifery at the Community of Hope Family Health and Birth Center. We have Dr. Eugene DeClercq, Professor and Assistant Dean for the Community Health Science Department of Boston University School of Public Health, and Stephanie Glover, a Senior Health Policy Analyst for the National Partnership for Women and Families. I'd like each of you to give your opening statement, please. Thank you.
Oh, am I first?
Go for it.
I'll go first. That's fine. Good morning. Thank you so much for inviting us to this panel today. So today I want to set the stage, as Nicole mentioned, in regards to the definition of maternal mortality and what we're currently doing at CDC. So tragically, our best estimates are that 700 women die each year in the United States from pregnancy complications and delivery. Further, considerable differences exist by race ethnicity, with Black women being 4 times more likely to die from pregnancy complications than white women. Not only are some pregnancy complications more common among Black women, but when experienced, the symptoms are often more severe. Shalon Irving was a colleague of mine at CDC, and she has been profiled in numerous publications and editorials about the Black-white disparity in maternal mortality, one of the highest disparities in our nation. And her bachelor's degree, 2 master's degrees, and a PhD should give us pause, as highly educated Black women are more likely to die from maternal deaths than white women with less than a high school education. So I'm here today as CDC is committed to preventing pregnancy-related deaths and ensuring the best possible birth outcomes. CDC works to support national surveillance to understand trends and patterns in pregnancy-related deaths. In addition, with the partnership with the CDC Foundation, Merck for Mothers, the Association for Maternal and Child Health Programs, CDC is supporting a critical project to support states and local jurisdictions to review the circumstances of each and every one of these deaths. By leveraging the findings of these maternal mortality review committees, we can find ways to reduce pregnancy-related deaths. A recent report from this partnership found that 60% 60% of pregnancy-related deaths are preventable. The leading causes of deaths vary by race. So for example, 12% of maternal deaths among Black women are due to preeclampsia and related conditions, where only 5% of maternal deaths among white women are due to this condition. And I have a handout with me today at this table that's demonstrating some of the findings from this 9-state report. So with better standardization and understanding of the data, we can identify interventions that will have the most impact and ensure quality care in the right place at the right time for all women. CDC will continue to provide technical assistance to states and their review committees. To date, over the past 2 years, we've had 48 jurisdictions come asking us for technical assistance with their maternal mortality review committees. In addition to ensuring robust data, we must continue to build the evidence of the effectiveness of innovative models of prenatal care, such as community-based supports, such as doulas and home visiting programs. These culturally resonating models of care that meet women where they are can have a role in improving birth outcomes. Efforts are needed to reduce variation in the care women receive and ensure moms and babies deliver in the best hospitals best suited for their needs. We can rigorously implement quality care initiatives that have been shown to reduce complications and close the gap, and do so in ways that ensures everyone gets the best quality care every time. And high quality care must extend into the postpartum period up to 1 year post-delivery when many of these deaths occur. We must listen to women as they know their bodies and understand when something is wrong. Of note, we cannot wait until a woman is pregnant to address her health and should aim to improve access to quality care across the lifespan. Most importantly, it will take a multidisciplinary approach as the social determinants of health, factors associated with where we eat, live, play, and work have a larger role than any clinical intervention that we can put in place. It is important to address things like jobs and educations in impoverished and distressed communities, and by addressing discrimination and racism to improve the social context in which women are giving birth. We must all work together to have collective impact to reduce disparities and reduce maternal mortality. Thank you for inviting me to this panel on the heels of Black Maternal Health Week. When we improve the life and health of mothers, we improve the life and health of families and communities. Thank you.
Thank you. Dr. DeClercq?
So I come here as a researcher primarily, but I'm also on the Massachusetts Maternal Mortality Review Committee. And the research I've done over the years, and clearly it's been a lot of years, has focused primarily on gaps, places that haven't been researched. And so I was part of a collaborative team that looked at a series of studies called Listening to Mothers, mostly because we found that nobody was listening to mothers. And I would encourage you, if you're interested, Google it. Stephanie's site has all of that material there available to you, and we give away everything we find. We got into maternal mortality partly because the United States hadn't published a maternal mortality rate since 2007. And so another group of colleagues and I tried to develop ways to figure out what was the national maternal mortality rate. And that led me into all of this research I'm going to talk about now. You'll hear a lot of statistics. I want to give you some things that probably you don't hear as often. You've heard about the fact that the disparities in black-white maternal mortality are about 3 to 4 times. When you look at it over time, what's really striking is the black-white difference in infant mortality is about 2.5 times. And the question that comes to mind, of course, is why is the disparity even greater for mothers than it is for infants? The infants' disparity is terrible. The one for mothers is even greater, and I think that's a question we have to wrestle with here. A second factor is familiar finding, right? That if you look at the United States compared to other industrialized countries on maternal mortality, we rank last. But if you only looked at white mothers and the rate for white mothers, what you would find is we're still last. And so disparities are a huge problem, but there are systems problems in the United States as well that we have to address. And that's a piece that doesn't get nearly as much attention. The next piece I'd like to really focus on, it's been much of the emphasis of my research in the last year, is from studies at CDC, they looked at timing of these deaths, from pregnancy all the way out to a year afterwards. And what you find is only about a third of the deaths occur at birth or within the week after birth. And much of the attention, and certainly most of the media attention, has been on those deaths. And they're tragic, and they need to be avoided, and many of them are preventable. But we lose sight of the fact that this isn't a clinical problem alone, it's a public health problem. And we're losing women during pregnancy, and we're losing women postpartum. And I think that's a challenge we need to face. It doesn't make for as neat a set of stories as ProPublica and others have put out that focus on the tragedies during childbirth. And those are real, and actually, if you look at trends in maternal mortality by cause, what you find is the clinical causes have been going down in recent years. The non-clinical causes have been going up in recent years. And so we've made a real national effort to try to improve things on the clinical side. We need to make a comparable effort to address the public health side, though that's a more complex issue to deal with in many ways. If the problem actually extends out to up to a year after birth, then the question becomes, how do we lose women at that time? And one of the ways we lose women is if you look at the patterns of Medicaid coverage, when a woman becomes pregnant, she's much more likely to be eligible for Medicaid coverage. So Medicaid coverage nationally goes to about 133% of the poverty level. If you're below that, you qualify. If you're pregnant, it goes up to about 203% of the poverty level, and you qualify. But what happens is in most states, my own state included, after 60 days, you're back at the other level and you're thrown off. But a third of the deaths are happening in that period, in that latter period that we cover. So I think we have a crisis here. And the crisis is not a maternal mortality crisis, actually. The crisis is a public health crisis about women's health in general. And this came to me because of other research I'd done over the years where we were looking at postpartum depression, and we found high rates of postpartum depression. And then we looked at it over time, and what we found was that a lot of the postpartum depression was actually chronic depression. It was chronic depression that we happened to be measuring in the postpartum period, but it was lifelong depression, a longer-term depression. We happened to be measuring it at that point in time. And I think the same thing is happening here. If you look at death rates for women over time, this is the kind of fun stuff I do. This is my life, right? If you look at death rates of women over time, you find that for ages less than 15, more than 40, those death rates have been going down consistently for the last 20 years. If you look at women of reproductive age, they're not. They've stayed flat. So it's not the 700 deaths that we need to be worrying about here. It's the 75,000 deaths of women of reproductive age that we need to be focusing on and establishing systems that address those kinds of problems. I'm a data person. I have data to back all this up. I would encourage you, there's a website we use called Birth by the Numbers. Last night we posted data to back up everything I've just said. You're welcome to go and download all. We give it everything on Birth by the Numbers we give away. I would encourage you to go to the site, download the data, and come up with your own solutions in your own settings, because this is not going to be solved at the national level. This has to be solved at a state-by-state level.
Okay, thank you. Stephanie.
Great, thank you. Thank you so much for asking me to join this panel. I'm Stephanie Glover. I'm with the National Partnership for Women and Families, and we have long advocated for health system changes that would better suit the needs of women and families, and have also long had a focus on the needs of pregnant women and new mothers. So I'm really pleased to be here to talk about this crisis and join my distinguished colleagues here. As has already been mentioned, we know that the racial disparities in maternal mortality have been around for years, but we also have seen an uptick in news coverage and public discourse around the issue, and I think it's worth reflecting on that, because it does really highlight this issue in a way that is more accessible to the general public, and the stories have been really moving. And I think when you sit down with all these articles, whether it's the New York Times article that was really well done that came out this weekend, or the NPR and ProPublica articles, a common theme emerges, and it's that a lot of these women had warning signs that they brought to their providers, to their healthcare system, about healthcare needs that they had, or something didn't feel right, returning to the doctor multiple times, and the healthcare system failed to listen to them. And I think that that is a real important piece to hone in on, which is that our healthcare system is not listening to women, it's not listening to pregnant women, and it's certainly not listening to Black women. And I think these are all drivers in this current crisis. And there are things we can do about it. We can fix our health system to better listen to women, but it's hard to listen to women when they're not connected with the healthcare system. So as Jean was mentioning, insurance coverage, having access to care are really key to improved health outcomes. But research shows us that women of color and low-income women are less likely to hold insurance. They also are more likely to report that cost is a barrier to needed care. I think the most recent data shows that approximately 12% of adult Black women lack insurance, and many of them are concentrated in the American South, where states have failed to expand Medicaid coverage. And that's a choice that policymakers are making, that states are making, to leave these women out of our healthcare system and not to provide that connection to needed healthcare providers, while we're experiencing this current maternal mortality crisis. I also think it's hard to listen to women when we have a healthcare system that incentivizes providers to work quickly through a large patient population. There's not time for providers to build trusting relationships, to understand and to listen to women about their life circumstances that are impacting both their health and their pregnancy. And that's the healthcare system we've set up, and it really does not incentivize the kind of care coordination, cultural competency, and addressing non-clinical needs that would really be key in solving some pieces of this crisis. As Jean mentioned, we have a National Listening to Mothers survey that does exactly that, listens to mothers and understands better their experiences with childbirth. And our last national survey found that 1 in 5 Black or Latina women reported poor treatment by hospital staff due to, I want to get this right, so I'm looking at my notes, due to race, ethnicity, cultural background, or language. So what that tells us is we currently don't have a healthcare system that provides culturally competent care, that provides a setting where women can share what is happening with them, both related to their health and outside of the doctor's office, which we know, again, are key drivers of their health. So we're not providing the kind of health care that would allow providers to listen to women and to address some of these upstream issues like housing, food insecurity, do they have a safe place to live, and are they having all their various healthcare needs addressed during a really key time of their life during their pregnancies. So we don't have to settle for a healthcare system like this. We really can drive change that will ensure that women and women of color in particular are better listened to in our healthcare settings. And I think that that is going to be a real key piece of the policy puzzle and the quality improvement puzzle as we do work to solve this crisis, reduce the really stark racial disparities, and ultimately ensure that all women have access to evidence-based, high-quality maternity care. Thanks.
Thank you. So, last but certainly not least, Ms. Ebony Marcel.
Hi. Thank you so much for inviting me today. I'm pretty sure they invited me because it's good for you to know that midwives don't all wear Birkenstocks and broom skirts and work in, only outside of the hospital. But I'm here in DC working for an amazing nonprofit, Community of Hope, that is a federally qualified health center that is attached to a birth center, and there are only 5 in the country right now. 10 years ago, there were 13, and it's a model that has decreased, but actually should increase. So as we're talking about maternal mortality, infant mortality, our program, our model is a great example of what's being done intervention-wise to have better outcomes. So for those who don't know, midwifery care is really about relationship-based care. And for disenfranchised and powerless women, it's key to have care that is culturally aware and also empowering. And so the midwifery model works really, really well in these settings. We care for wards, primarily wards 5, 7, and 8 that have the highest numbers in maternal mortality, infant mortality. And we provide services like centering pregnancy, which is a model of group care, prenatal care that starts around 6 months. But in our centering, I've created to where we focus on the things that we need. So there's heavy nutrition, heavy breastfeeding. We have a semi-mandatory yoga session to try to address some of the stress. We offer free yoga once a week at the birth center, but we also have wraparound services. So I have a prenatal care specialist, I have a postpartum care coordinator, I have a reproductive health coordinator, I have a in-house lactation specialist. Our medical services has integrated behavioral health, and so we're able to kind of like bear hug these women and give them all the things that we need. We also partner a lot with another organization called Mama Toto, and we are proud. We are proud for what we're doing right here in Ward 7 and 8, and we feel like it should be replicated because we have better outcomes, less low birth weight, less preterm birth weight, higher breastfeeding, higher contraception initiation, and most of all, more maternal satisfaction. The women are happier, and we don't have maybe the no-show rates of other clinics where patients are not coming in for care. They come for their appointments, and they have just better experiences. So,
So, Ms. Cox, so we talked about the maternal mortality crisis, that it traverses race and ethnicity, but there is a very specific phenomena called weathering in my studies that I was reading about. Can you just tell us a little bit more about weathering and how that affects the mortality rate?
So some researchers, especially Dr. Geronimo, has done some work over time to show that actually the healthiest time for a Black woman to have a pregnancy is at age 19, because over time, as you know, experience of being a Black woman in this country, and as you age over time, you actually have worse outcomes. So where you would assume that older women in their mid to late 20s would have better outcomes than younger Black women, actually younger Black women have better outcomes. And you see the reverse with white women, where older women actually have better than young white women. So there is something particular about the experience of being Black in America. You also see this, it's called the Latino paradox, where Hispanic immigrants come to this country and they have better health outcomes than actually white Americans for a lot of outcomes. And then there's the shift as second and third generational immigrants actually start to experience adverse outcomes as the rate as Black women, especially when you're looking at Puerto Ricans and some other subgroup of Hispanics. And you also see this for Caribbean and African immigrants that come to this country. There's an assumption that it's a genetic component of race to bad maternal and infant outcomes, but really, when African and Caribbean immigrants first come to this country, they have outcomes comparable to white women. But again, if you get to the second and third generation, they shift to as if they were born in this country. So there's definitely something specific to being Black in this country, and over time, the continued assaults over time that definitely impact.
Tiny insults.
Excuse me?
Tiny insults, microaggressions.
Yes.
I think that's what they're calling it, yeah. So yeah, that's very interesting. Now, Dr. DeClercq, so you kind of talked about the mortality rate, and of course I actually read your Green Journal study, but can you tell us a little bit about the maternal mortality ratio? Can you define that for our audience?
This gets a little bit in the weeds, but
We love it, we love weeds.
So we actually have 3 different ways we're now trying to measure maternal mortality in the United States, and that's partly because people don't talk to each other enough. Nobody listens to anybody, apparently. The classic one is there's a national vital statistics system that collects death data, and that's one we've worked with. That's the only one that's public. Anybody can actually work with it. It's not simple, but it's open to the public to use. The CDC has developed its own measure, which is pregnancy-related mortality, and they gather data from all of the states. The states sign agreements with CDC, send the data to CDC, and CDC analyzes that data. If you're looking for reliable maternal mortality rates, the CDC data is the most reliable system we have. The National Vital Statistics System has run into difficulties largely because of good intentions. They tried to improve the system. Improving the system didn't work as well as they'd like, and so there is no clear national rate. There's a third system which is being developed at CDC, which uses data from all of the maternal mortality review committees around the country. There's a standardized form. Everybody's trying to submit it to CDC, and hopefully that is a richer data source. Because there's two levels to this, right? One is simply the recording of the information, but the second is all of the additional information you need to be able to make decisions. All of which is to say, if you want to get a good sense of what the national maternal mortality rate is in the United States, I think the most reliable estimate is around 14 per 100,000. That's using the CDC's pregnancy mortality surveillance system and then adjusting it. The CDC, for reasons that go to bureaucratic infighting, only reports out to a year. So they report this pregnancy related. So it's deaths in pregnancy, at birth, or out to a year. The international standard is maternal mortality ratio, which is pregnancy, birth, and out to 42 days. For reasons that are beyond imagination, CDC cannot adjust its data to report that. Only the National Center for Health Statistics can do that. They haven't put one out in a decade. All of which is to say, if you want a reliable number, I would look at the CDC data. If you want to use it for international comparisons, you have to do an adjustment. This is not another plug, but we did that. On the website, we have all that laid out for you if you want to take a look and see both what the most reliable measure of maternal mortality is right now and how it compares to other countries. The other thing that we have to get rid of is when they say the US is 35th in the world or 42nd in the world, that's comparing us to countries that don't have anybody living there. They're comparing us to Andorra and San Marino and that. So what you really want to do is compare it to countries that have comparable size populations. And if you do that, we're still last. It doesn't improve us at all. We're not 35th, we're 13th out of 13, but at least it's a fair comparison and a more reliable comparison. And the other thing that's striking is we've looked at this over time, and if you look at it over time, what you find is that for things like infant mortality or perinatal mortality, the rates in the United States have been going down. But they've been going down slower than the rates in those other countries, and those other countries were doing better before. In other words, we started off worse and we're falling further behind as time goes on. Not because we're not improving, it's because we're not improving as quickly as other countries who are already doing better were improving. Last point on this, when you do that with maternal mortality, what you find is the other countries stay pretty flat. They don't decrease their maternal mortality rates very much. And it's not necessarily because they're doing so well and can't improve anymore, it's because they're doing a better job of identifying cases. And so as a result of doing that better job of identifying cases, the actual rate, they're probably getting closer to what an actual rate is, and that results in it being flat. The US is doing a better job at identifying cases, and the result has been our rate is going up. Now, the issue then becomes, does that mean the rate's actually going up, or does that mean we simply were not gathering the data correctly before? In other words, we're not increasing as much as we thought only because we were doing worse before than we thought. And now we're doing a better job of identifying cases, and the result is our rates are going up. And once again, the disparities between the United States and other countries are increasing, not decreasing over time.
So you actually talked about these MMRCs, these maternal mortality review committees. Now, does every state have one of these wonderful committees where everybody gets together and talks about the data and what we can do?
No, I think our best estimates are about 27 states have active committees. A lot of states are coming on board. Like I said, we're getting a lot of technical assistance requests in regards to who should be on these committees, because it really has to be a multidisciplinary committee. As mentioned by other panelists, you need midwives, OBGYNs, folks that understand the social determinants of health to really be able to look at these cases. For a lot of states, it may be that they establish a committee and it's on a volunteer basis. So when that volunteer leaves and moves on to something else, the committee falls apart. Where you see the most traction is where there's legislation and funding towards maternal
Right,
mortality
legislation
review
and
committees. And that gives states the ability to kind of have some support. And it may be something as simple as someone who's able to go to different hospitals and abstract data. Just funding a position as simple as that helps create sustainability over time for these
These are
review
volunteer
committees.
positions for the most part,
For
yes?
the most part, they are volunteer positions.
Oh, volunteering, okay.
I mean, if done correctly, it's a combination, right? I'm on the Massachusetts one, and it's the members of the committee are all volunteers, but the State Department of Public Health provides the infrastructure to make this work,
Right.
and so it's a bit of both. And the states that have picked them up and done the best are the ones that have some kind of infrastructure behind it, because you can't rely on volunteers, and certainly in the bigger states, they can't look at every case. There's too many cases for volunteer committee to look at, so they need somebody to abstract the cases and look at a smaller number.
So we're talking about, legislation and funding. So, Stephanie, can you tell us a little bit about what kind of policy changes are out there right now? Like, what could people in the audience call their congressperson and say, hey, add your name onto this bill?
Sure, happy to discuss that. And I mean, I think that there are a couple bills being circulated at the federal level. I think the one that has gotten the most traction is the Preventing Maternal Deaths Act, and the Maternal Accountability Act has a different name in the House and the Senate, so apologies if I got one of those wrong. But that is a bill that
HR 1318 and Senate Bill 1112, just in
Perfect.
case anyone
Yes,
wants to
thank
write
you.
that
Didn't have that at the tip of my finger, so I appreciate that. And those are the two bills that would create the funding to support these maternal mortality review committees. And as my colleagues have already mentioned, those really are the gold standard in maternal mortality surveillance and do require funding for states to do them well. So those are the main bills that are moving right now. I think it's also worth pointing out that there are activities in the states that are already happening to change the way we deliver care to women, and that doesn't necessarily mean those changes don't necessarily require federal policy change at the moment. There are changes that are happening where we are seeing improved outcomes. And I think the example that Ebony provided of the care that her practice delivers is similar to what we're seeing in a lot of places. And these are just really demonstration projects, pilots, where we're beginning to see promising results of things like group prenatal practices and birth center practices and maternity care homes. Maternity care homes are one in particular where I think we're seeing promising outcomes. North Carolina has a statewide program of maternity care homes in their Medicaid program. Again, we're just looking at early results from these programs, but we are seeing improved outcomes for women, and we are seeing in North Carolina a slight narrowing of the racial disparity between Black and white maternal deaths. And I think those are worth highlighting because they're already in place. So other states can do this, and other states are considering things like maternity care homes. And what those really are a way to facilitate care that better coordinates a woman's care, particularly for higher risk women, and also does a better job connecting women with the non-clinical supports they need. Again, Ebony described a lot of this in her work, but the ability to address the things that affect your health outside of the doctor's office. So like good food, a safe place to live, a way to get to the doctor, having reliable transportation. So I do think there are changes happening in the states that don't require federal policy change that we can point to and advocate for as ways to improve outcomes and reduce disparities.
So you kind of talked about, Ebony, you kind of talked about how these models that we're instituting on a smaller scale are getting us better results. And what kind of results are you seeing in your practice where you have this kind of integrative model of care in terms of stats, if you know anything?
I do.
Great.
I think one of the things that I definitely want to point out is that, a lot of Black women may not exactly be high risk medically, but they're high risk socially. And that's important for you to kind of know the difference and understanding how much those factors play into her overall care, her pregnancy, and her experience. But what we're finding is that we had, and these are rough numbers, but we had about 170 moms last year in centering pregnancy, and out of that 170 moms, we had 2 preterm and 4 low birth weight. That's like nothing. compared to, what other practices or folks are experiencing in our area. But we're still struggling with the fact that a lot of women are still not coming in for care. And I think it's time for us to also add to this conversation about the generational distrust with the medical system. And if we don't have that conversation, we're not going to be able to really appropriately address how the women are receiving care or why they're not coming in for care. We're seeing, I feel like, amazing breastfeeding numbers. I just started a new program, an early postpartum group, not necessarily focused on like centering, which is about prenatal care and education, but this early postpartum group, I have them come in for 2 hours. The lactation specialist does a 2-week check-in, because anybody that's breastfed knows at 2 weeks, you feel like a human cow. They're always nursing and you're scared to death that this will never end. So we have a lactation person. The reproductive health, our reproductive care coordinator comes in and discusses all the contraception options for what she can have since she just had the baby. Our postpartum care coordinator sets up home visits to come by and see her and check on her and the baby. Our behavioral health specialist comes in and has a good discussion about blues versus depression, what was going on possibly before, and offers appointments that same day or the next coming days if she wants to be seen. And then she also gets seen by the midwife. And we also do, the midwives do I don't know, I think a lot of people know this. Midwives do newborn care. So we see our babies that we've caught the first month of life, and then we transition them to our family practice providers. So at 2 weeks, they need a weight check. So it's lovely. So they come in, they do their 2-week early postpartum group with us. We do a weight check on the baby, and it's comprehensive and together. I'm sorry.
That's wonderful. Oh, okay. So in comparison to your data that you're doing in your model, compare that to maybe the rest of the city or people who aren't kind of those women who aren't in that type of care model. So in yours, nobody died.
Right.
Yeah,
Nobody died.
Right.
Knock on wood, let's keep that going. I think what I hear from a lot of the community-based clinics is that it's really hard to get women in postpartum period. Some of the return rates are as low as around 30%, which is really, really low. And that's important because, like Jean was talking about, a lot of deaths are happening in that period. There's a lot of undiagnosed pre-pregnancy depression, and that increases your chances of postpartum depression. And then, unfortunately, our medical model, not the midwifery model, has women coming back in at 6 weeks.
6 weeks postpartum.
Which drives me crazy, because we need to see her earlier, because a lot of her problems are developing those first couple of weeks. So what I feel like I'm hearing from a lot of the other community-based clinics, non-midwifery models, is that they're struggling to get people back in, seeing a lot of short interval pregnancies. That's where folks are pregnant again, whether they wanted to or not be pregnant.
And that's an inherent risk right there.
It's a huge risk. So, it takes time for the body to recover after having a baby. So getting pregnant so soon after just having another baby definitely increases the risk, especially if that pregnancy was complicated with hypertensive disorders like preeclampsia, or just, even smaller things like anemia. So, I think what I'm hoping that we're doing as we're growing this program and having these conversations and I'm able to talk to folks, I want folks to understand that there's a huge cultural awareness piece that needs to be added to our healthcare. Another thing that I always like to point out is it is massive for me to be a midwife of color in leadership. Midwives of color make up about 2% of the entire midwifery profession. I said 2%. So they have let me, so I've hired a majority midwife of color staff. And I think that's what's allowed our practice to almost triple in the 3 years under my leadership, is that people are seeing people that look like them. It's a huge impact on women who feel very distrustful and scared to get care.
Yeah. So we actually kind of talked about expansion of Medicaid and what that might be able to do. So why is expanding that Medicaid, why is it so important to the system? Why is it? Anyone?
Well, I mean, I think as I mentioned, waiting until a woman becomes pregnant to address some of the conditions they may have, whether it's depression, hypertension, nutritional issues, we really need to be able to have continuum of care. And in order to have continuum of care, one of the best ways to do that is to have health care coverage to access care. So really, that is the opportunity for Medicaid expansion. And in addition, thinking about innovative ways to reimburse providers for the care that they're receiving. So for example, the Centers for Medicaid Services has a maternal and infant health initiative. And one of the things that they're looking at is how can you reimburse community health workers, doulas, et cetera, for what they're providing, the services they're providing to have that continuum of care.
All right.
Actually, I want to make two separate points.
Sure.
One is just to follow up on Ebony's point about birth centers and those listening to mothers' surveys that we do. Those are surveys of mothers who have just given birth in a hospital. But in them, we've had a question on, in a future pregnancy, would you like to use a birth center? Would you like to have a home birth? And about 25% of mothers actually say home birth. The highest proportion is among African-American mothers who say that. 64% of the mothers said that they were interested in a birth center birth. Now, these are women, and this is a birth center separate from a hospital. These are women who just gave birth in a hospital, and that's the number I like to use the most when I do grand rounds to obstetricians in hospitals, because the question, they don't invite me back, but for that one, I at least get to make that point that what's going on in the hospital that causes mothers to say, in a future birth, I would like to give birth outside of the hospital in a birthing center. And I think that's the important question, because at the end of the day, I'm a big advocate of birth centers, obviously, but most mothers are still going to give birth in hospitals. We need to restructure hospitals so mothers feel more comfortable about the care they're receiving there.
Yeah, exactly. Go ahead.
On the issue of coverage, so I said I'm on the Mass Maternal Mortality Review Committee, and obviously I'm not a clinician, and so I don't get the clinical case. We divide clinicians do the clinical cases, and I do the sort of social cases. And the first decision for a review committee is basically the state will do a run, and they'll get all women who died within the time periods we're talking about, from the beginning of pregnancy out to a year afterwards. And the first decision, and those are called pregnancy-associated deaths. There's not saying it's related to the pregnancy, it's simply timing. It happened to occur during that time period. And the first decision we have to make is, was it pregnancy-related? Because then you can make recommendations about pregnancy care. But it strikes me, because I get a lot of the cases that are more what would be really pregnancy-associated. It strikes me that we're the people now who are looking at the tragedy of women's health care in the United States generally, right? Because those pregnancy-associated deaths, they may not have been a result of the pregnancy, right? It may have been a result of chronic issues that have happened that well predate that pregnancy. It may have to do with substance issues that well predate that pregnancy. And you look at the lives of these women between substance and violence and all the other things that capture, and then we have to wrestle with the question of, was this pregnancy related or not? And even if we do say it is, the question then becomes, was it preventable? Because that's the next question for review committees. Was it preventable? And we noted the 60% rate that CDC puts out, 60% of them are preventable. Honestly, sitting in that committee, we wrestle with this argument all the time, because the question is, it would be preventable with a really functional system that identified women's health issues early on, got them into care before they got pregnant, maintained that care during their pregnancy and postpartum. That's preventable. But then we go back to, but our system isn't anything like that. And this is in Massachusetts, by the way, which has pretty good social services and focuses more than most on social services. And we know there isn't a system like that that exists right now. And so the reason for arguing for Medicaid expansion, the reason for arguing for greater focus on all of this, is that if we don't have a system, then what are we referring those women to? What are we saying? That you have coverage to get care, but the care is inept? Not inept. Caring people who are overstressed, who don't have enough time to pay attention, who don't have enough support to do the right work, and women then fall through the cracks.
Exactly. Certainly. Yeah, go ahead.
Yeah, I just was going to jump in on the insurance coverage piece, which is that the connection between insurance coverage and health is well researched and documented, that having insurance coverage whether it's private insurance or Medicaid, does improve people's health, and that's particularly true for uptake of preventive services and also access to primary care. So as my colleagues were saying, ensuring that women are able to see their provider before, during, and after pregnancy really does require that we have affordable quality insurance available for all women throughout their lives, not just when they're pregnant, although that's critical. And that's going to improve overall health as we work towards also improving maternal health outcomes.
Please.
I just wanted to add an example of what you're talking about exists with Mama Toto Village. They are able to get Medicaid to pay for their perinatal health support workers, and it is incredible. So basically, to give you an example, if I have a mom that is, freshly postpartum and is struggling, sometimes they come in and they haven't eaten. In DC, we deal with a lot of housing. There's all different types of homelessness in DC. You have some that are in the hotels, you have some that are in the shelters, you have some that are staying with relatives and they're being paid. And so if she has no food, and I need her to have better lactation because maybe her baby's smaller, I can call Mama Toto and she can get somebody to their house and get paid through Medicaid that same day. So it really, really works, and we need more of that.
So that's on a DC level, right? With getting paid for Medicaid. So could that be possibly expanded to other states? Now, how could that possibly work?
I hope so. I mean, I think AZA is working really hard to let people, share her information and let people know that this model could be expanded. I hope it's expanded soon.
I think the financing piece is really tough because our current healthcare finance system supports a fee-for-service system that is rapid intake of patients, and yeah, you live it, right? So exactly. So there is a need to get creative with financing so that we can support more innovative models. But Medicaid does provide a lot of flexibilities for states to do that. It really is a federal-state partnership, and states are creative with how they can fund innovative models that ultimately save them money by improving outcomes. I believe in Kansas City, so I'm not sure if it's Missouri or Kansas, they are doing some innovative work with their Medicaid managed care plans to incorporate more non-clinical needs for pregnant women. Minnesota has tried to do more reimbursement for doulas. So there are opportunities for that. The financing is not an easy piece, and there's a lot of research and study on that right now, but there is flexibility in the Medicaid program to address some of these needs.
Okay, wonderful. So kind of thinking more about data and getting accurate data and how difficult that is. So as a physician, thank God, I've never had to fill out the death certificate, but when we're talking about medical liability and who's to blame and all of that, are the physicians and hospitals, are they anonymized? So then when we're looking at these data, do they know that this data is anonymized, that they would feel safe actually filling out the form in the way that it needed to be filled out so that we can get the data that we need?
So it depends, as usual.
Great.
Review committee data is anonymous. We don't know doctors, we don't know hospitals. I would imagine in smaller states they probably could pretty easily discern that, and there's oftentimes newspaper accounts of those things as well. But generally, it's anonymous. The difficulty is not so much, I think, fear as inattention and other things to do. And so the difficulty we've had in counting in the United States stems from this attempt to try to improve measurement by adding a pregnancy checkbox to death certificates. And we always assume, probably because of CSI and those shows, that there's this elaborate analysis that's done on each death. And the fact of the matter is, it might be a funeral director in a small state who's actually filling that out. And so what we found was, if you look at the death rates for women over 40, according to this, they've jumped enormously. But the fact of the matter is, other examinations of maternal mortality don't show that. What we found was random error probably accounts for that. Not systematic, not trying to bias anything, but simple random error. The jump in the death rates, maternal death rates of women over 40 probably is accounted for by the fact that more women over 40 die than women who are in their 20s. You apply random error to women in their 20s, not many die, so it doesn't have much impact. You apply it to women over 40, you get this big jump. Again, this is about systems, right? This is about systems of care, systems about measurement that have quality controls that go back and check on these things. Again, one of the values of maternal mortality review committees is they do go back. We do ask those questions and go back and explore it, but that's those volunteer committees, once again, trying to do that.
So you said
work.
17 states, I believe, right?
It's about 27 states right now that have codified maternal mortality review committees.
So do those states have better maternal death rates than the states without the maternal mortality review committees?
Not specifically. I mean, again, it's having that support at a state level and a legislative level. Speaking to your question, for example, some states have it codified where it is anonymous reviews, where there are protections for physicians so that the findings that come out are used for prevention and not for other purposes. So really and truly, as Jean was saying, these states are able to link data. And so if you have an abstractor where your experience delivering a woman in a hospital and the information you're providing is very limited to that experience, whereas being able to go back and link to prenatal care records, link to social services records, link to domestic violence and other things, police records, you're able to get a more comprehensive picture of the social context that that woman experienced during pregnancy and in the postpartum period. So really, as others have mentioned, it's not a provider-only system. It's really looking at what's the entire healthcare system, where women are coming in, the services that they're having. A lot of the work that CDC is doing also, and Jean works with this, is perinatal quality collaboratives, really having quality indicators that you're looking at, rapid data for improvement. So everyone who's coming in with these bundles of care is receiving the same care each time, every time they come into the hospital. So being able to kind of have these bundles of care around hypertension, around substance abuse, around early elective cesarean deliveries, being able to look and say, these are outcomes that we need to work on based on our maternal mortality review committees. A lot of times when they have recommendations for prevention, it may be that they may find that control of hypertension or dealing with hypertensive disorders in that hospital may not necessarily be getting standardized care over time. So how can we then take that information back to our perinatal quality collaboratives and have a statewide process where all the hospitals in the state are implementing these bundles of care, having rapid feedback to hospitals, to physicians, where there may be missed opportunities and improving outcomes. And that's really a way, and again, it doesn't address some of the structural issues, but it addresses some of the provider issues where everyone, again, is looking to provide the same care every time and reducing that variation in care, where you see that some hospitals, so for example, some minority hospitals may not be providing quality care. And so how do you then go to that hospital, implement these bundles of care, and ensure that everyone is getting the right care every time?
Right, so we're talking about structural issues here. So here, let's kind of move a little bit, shift a little bit to to policy changes, and then we'll take a few questions from the general body. So if federal funding were no object, what would you, we gotta end on a high note. What would you see us being able to do to really thwart this problem? Start wherever.
This would be the same world in which I'd be taller, younger, and better looking.
Absolutely.
It would be the coordination of care, the focusing on coordination of care and not putting it all on clinicians. I can give you an example. This is actually, it's more an amalgam of a few cases we had. I don't want to focus on one. You get cases of women who have issues with substance. And they go through extraordinary lengths to change their lives during the pregnancy because they focused on having a healthy baby. And they make that commitment, and they'll get into a program, and it'll be a supportive program. And once they have their baby, the Department of Children and Families still comes in and takes the baby away because of the rest of their lives have been pretty chaotic, and the job of the DCF is to protect the children. The woman then crashes. It's not unusual that all of that effort was around the hope, and we've all dealt with this kind of situation where this will be the one that changes my life, this baby was going to turn everything around. The New York Times case talked about the same kind of phenomenon, right? And then she disappears from the system, and they find her dead, either overdose, suicide, some other condition like that. We were at a regional maternal mortality review committee meeting, and I asked the people from the other state, this is New England states, I said, we all have cases like this. Do you have a system that follows the women afterwards? And it's like when I ask a tough question in class and no one wants to make eye contact and everybody's looking around and avoiding it because everybody said, well, we sort of have something like maybe does this, but we don't have a system. We don't have a system of care. The New York Times piece had a wonderful description of what a doula does.
Yes.
And we have this misunderstanding about doulas that they support women during labor, and they do, they're fantastic at that. But the doula role has been expanded, and there are doulas who work with women during their pregnancy, during childbirth, but also postpartum. Honestly, that's the kind of system we need, because one of the things the piece points out is the degree to which the doula was able to identify situations because she knew the mother. Yep. Identify situations that no clinician, unless they're breathtakingly sensitive, would have picked up. You need to have enough context to be able to pick up those signs, and she did. A system that supports that provides that greater continuity of care would be the way to go. We are nowhere near that, but that, if you ask me, if we had the funding to do that, because what would happen then is, what we need is sort of, everybody needs a doula, right? Not just pregnant women. I don't mean just pregnant women. Right. I mean, we all could use a doula. But yes, please God. But the issue, as I said, is not just about pregnancy. Yeah. It's about women at risk, and women at risk need doulas. Exactly. And of some type. Yeah, they need support of some type. Yeah. But that's an expense that's very hard to get justified on a widespread basis.
The problem is spend the money now or spend the money later. Right. Yeah.
But we don't have a system focused on prevention. We have a system focused on care.
I know, I live in it. Yeah.
So I'll just add on to that and say that if federal funds were truly not an obstacle, I think that we could be financing all of the things we're talking about, right? So it is the better coordination of care. It's also addressing the non-clinical needs. It's it's financing providers who can give that bear hug to the pregnant woman who needs more than just. Sorry, midwives, yes, let's be specific here. So we do need financing for all of that. I'll also throw in one additional policy priority that we have at the National Partnership, which is a national paid leave program, so that women have time to take time off if they are experiencing complications during pregnancy and they need to be home, or they need more access to their provider, and also after birth. And so, having a robust and comprehensive paid leave program for all workers is also going to go a long way to helping women meet the dual demands of work and family and improve their own health outcomes.
Absolutely, because a patient may not come back to a job if she takes the amount of time that she would need to heal. Everybody's not Serena Williams, who can spend 6 weeks in the hospital and still go work out and go and play championship tennis again.
Right, and I think the data also shows that Black women are more likely to quit or be fired from a job soon after birth, and that's definitely tied up into both pregnancy discrimination, but also the lack of a paid leave program. And so again, these are policy choices that we've made, and if federal funds were no obstacle, we could make a big difference here.
I have women regularly trying to go back to work less than a month out, even if she's had a C-section, and it's purely based on need. Can I tell my dream? If
Yes,
federal
please.
Was no? If it was my way, we would have a lot of federally qualified health centers attached to birth centers, because to me, that's the whole comprehensive package that a lot of women need. And just to also, give a shout out to doulas, there are lactation doulas, there's fertility doulas, there are postpartum doulas. Like, the doula role has become so huge and expansive, and it's amazing. So definitely lots and lots of doulas, maybe some doulas for men. And then another big thing for me would be more midwives and more midwives of color. we're known for having lower C-section rates and better outcomes. And I think it's related to the relationship-based care, and then also definitely more midwives of color. I think with disenfranchised, low-income Black women, they need to see people that look like them.
Yeah, absolutely. So I'd kind of like to just a little bit about what Representative Robin Kelly is considering bringing to the table. It's called Mama's Law. So Mama's Law is going to try to address actually many of the things that you talked about, because sometimes you just have to just put it out there and say, look, these are the things, we've already defined the problem, we know what we need to do, how about we just start to work on fixing the problem? So Mama's Law is going to designate the month of April as National Maternal Mortality Awareness Month. We're going to empower federal agencies with resources to accurately track the data like we talked about. Because if we don't know what the data is, we won't know how to fix the problem. We want to encourage, just like we talked about, standardization of obstetrical protocols. In my hospital, we have a hemorrhage protocol, we have a preeclampsia protocol, we have a C-section protocol, but these things took years, and when you do designate by committee, it does take years. And it's gonna take, it took us years to make this problem, it's gonna take us years to fix this problem, but these are the things that we need to do. We need to expand Medicaid to 1 year postpartum. That's kind of, we've already defined. We already see that this is a problem, so we need to make changes to fix the problem, as well as effectively addressing the widely acknowledged racial disparities in health systems to promote what's called culturally competent care. Now, at that, I'm going to open up. We have about 14 minutes and 37 seconds for questions. Please come up.
Dr. Renee St. Anthony, I'm so happy and excited to see that this has hit our agenda for the National Minority Quality Forum. My question is really about prevention. I am a physician and a maternal child health advocate and expert, and how we can have this discussion without talking about prevention and family planning. The intendedness of pregnancy we know has a huge impact on pregnancy outcomes and maternal mortality, but what are we doing to make sure that all women, regardless of race, socioeconomic status, et cetera, can actually plan their families? And that's something that's a cultural difference as well, about planning and when you decide how large your families are, when you're gonna have a baby. And that really comes back to that discussion of contraception, postpartum contraception, affordable accessibility to contraception, so that if you don't have unintended pregnancies and people have control of their own fertility and timing, that this alone will decrease some of the rates. So I'm curious in your thoughts.
Well, yeah,
on
that goes into what happens is that women don't have Medicaid oftentimes until they become pregnant. Therefore, her ability to access effective, long-acting reversible contraception, which is something that I do in my office every day, is limited. And that's where we need to bring it to before. We need to have, because when women are healthy, families are healthy. We know this. So before pregnancy, during pregnancy, and after pregnancy, absolutely. Anybody else need to speak to that? Because we got 12 minutes.
So some of the work that CDC is working with state Medicaid and state health officials is really looking for states to look at how can they increase access to contraception and understand that there are specific barriers to long-acting reversible contraception, primarily cost. And then really for African Americans, understanding and implementing it with a reproductive health justice framework. As was discussed before, is that there's a lot of mistrust in the medical system, where in California that they found that certain women are counseled for whether it's sterilization and certain birth control methods differently than privately insured women, and how do women feel when they're being counseled? Are they being coerced into different methods? And so there's really a lot of work in that area in regards to how do you bring folks into care earlier and understanding and planning pregnancies. One thing that I always say when I give talks is, Bristol Palin having an unintended pregnancy is a lot different than a child who's a foster care and about to age out of the system. So even with improving intended pregnancy rates, there's still a lot of research and kind of understanding there's a lot of ambivalence around around family planning, and as you mentioned, it can be cultural sometimes, where it's something that just happens. So how do we, work with populations for there to create a demand for these services, implement those services in a way that understands the historical context of how contraception was delivered in this country, and then help them understand how that can plan their pregnancies, space their pregnancies, address some of the things that were addressed by Ebony in regards to making sure that their experience with the healthcare system addresses their needs in the context that they are.
Thank you.
Hello, I'm Michael Knight. I'm one of the regional chairs for the National Medical Association, as well as on faculty here at the George Washington University. So thank you for your very interesting panel. And when we talk about examples and solutions, because I think we talked about statistics, but what actually is working, when we think about, for example, the program in North Carolina, where they have the pregnancy medical home, and they have pregnancy care managers that are working with the Medicaid population to have financial incentives for providers, having care pathways to limit variation in care. When we talk about solutions that are working, sometimes it feels that every different locality is having to start from scratch. And so are there initiatives, or is there a movement to look at programs like that are actually working, and that we see data of improvement of mortality rates, and how are we bringing that or allowing that to spread across the country?
Yeah, it's interesting. How do we share what is working and implement it in different places?
Yeah, so I think, again, the state quality collaboratives that I've mentioned, where you're having statewide initiatives where all facilities are coming together to implement these quality care at the same time, working with academic researchers to publish information, and then, the role of whether it's nonprofit organizations, federal organizations, policymakers to kind of translate that science, as we call data to action, being able to get those models of care and understand how they work, especially working with funders of care, whether it's Centers for Medicaid Services and some of the innovative models that they're working on. So again, being able to look at these models, understand the data, analyze the data. That's why we need good data. And so when you have good data to be able to understand the problem and measure what works and what doesn't, you're able to put together packages and translate that for wider audiences, for people to have the options to pick up some of these models of care.
Yeah, great, great. Over here.
Hello. Sorry. Hi, my name is Jason Young. I'm a post-bac student with Mentoring in Medicine. And my question for the panel is, what advice could you give to my peers at my alma mater, the University of Maryland, Baltimore County, in regards to maternal mortality in the community?
Advice for post-bac or post-doc?
Post-bac.
Post-bac, okay. Advice for a post-bac.
Go get a master's in public health, preferably at Boston University. Get more people engaged in this. I think the key point right now is, in 2 years, no one's going to care about this anymore, because we'll move on to other issues, and it's really hard to keep women's health on the forefront. And we have to use this moment to find ways to start spreading the word. I mean, picking up on the last question, this is the time that they could have a conference where they talked about solutions. In 2 years, it'll be hard to organize that. I think putting these kinds of things together would be exactly the kind of efforts at the local level that you could do that would start to bring together people who knew what was going on nationally, but could then apply it in the context that you're working in.
Yeah, and just to pick up on that point, I mean, I think the attention on maternal mortality in this moment is unprecedented. The fact that we're in the midst of the inaugural Black Maternal Health Week, that there's been so much media attention on this issue. I mean, I do think making sure that that attention carries through 2 years, 10 years, however long we need is really going to be key, because the New York Times published this article this Sunday, but they're not going to publish it next Sunday, right? So ensuring that drumbeat continues so that people are paying attention and policymakers are paying attention and actually enacting change that's going to have a difference.
Yeah. It depends on what you're looking for. I'm a physician, I wanted to go and care for patients. But if you want to be in a different aspect, yes, get the numbers. If you are a numbers guy, work on that part to make sure that we have enough data that when we're looking at these problems, we can define the problems, then we can fix the problems. Okay, let's switch over to this
Great.
side.
Good morning. My name is Jean Drummond with Healthcare Dynamics. I want to just kind of ask, typically I talk about policy to practice, but now I'm going to put payer in, right? So I've got kind of two questions. One is, when you think about where we're going, value-based reimbursement, CMS, MACRA, how does your service delivery, get paid? I know you spoke about, pay. So where are you? Because that's the sustainability, right? So just as we're providing free support to clinicians around MIPS. That's a free commercial. But I wanted to ask you about that. On the other side, when we think about practice, the community construct. So what are some of your suggestions? And I'm particularly interested in hearing what you're doing in DC, because I know, the challenges of where you are, to empower that community. Yesterday we talked about building sustainable communities. So that patient gets out the hospital, she's in her home. Help me understand that. So there's two sides, the payer construct, and then the place where the community, for the community side.
I'll let somebody else handle the payer piece.
Okay.
I think, but what I will say about me is, again, I'm housed under a federally qualified health center, which is huge.
Yes.
Because, I'm actually attending at Washington Hospital Center. I do deliver in the hospital as well as in the birth center. And when we think about OB, we think about OB malpractice coverage. And so federal tort. So that's one beauty
Thank you.
with us. And then definitely fundraising, grants, it's a hodgepodge of things. But as far as the community piece, I think the type of care that we're providing is empowerment-based care. And so having not only the wraparound services, but it's also the fact that we are, like I said, bear hugging these women. I feel like they come out of our care more, what's the word I'm looking for? Well, empowered, and we try to help them with all the different things that they have maybe challenges with. Like I said, our nonprofit also has a housing arm as well. Housing is an issue. Our postpartum care coordinator, if they don't have a GED, she helps them get any of their education needs set up. But also, I also want to point out, back again to my sister program, Mama Toto, that's not exactly with us, but we partner with. Mama Toto is hiring a lot of women in the community as perinatal support workers and helping them to get training to also do lactation. And I think that is massive. So I have a lot of former patients who have gone through her trainings who are now in the workforce getting paid for Medicaid to be a perinatal health support worker or a breastfeeding peer support counselor. Does that kind of answer?
Yeah, thank you.
Now, when we're talking about the payer piece, I'm a clinician, so I see patients and I like to get paid, and that's helpful. If we can prove to insurance companies, hey, these are the things that are working, this is how you would actually save money in the long run, then yes, then I think they will start to support and pay for these services because we're going to need the numbers. That's all there is to it, because they're not going to look at anything other than what's it going to do to my bottom line. And even as clinicians, we give care and we think, okay, so how is this going to affect my ability to pay my employees in 2 weeks? So these things are important, but once we get that data, so it all comes down to proof. The proof is in the pudding.
And I would just like to make the point, we don't have to reinvent the wheel in regards to that there have been experiences of other outcomes before us that have shown how this has worked. So for example, with diabetes care, there's been a lot of work with, with diabetes educations and the diabetes prevention program. And they went through a process in regards to showing that this program, the community health workers being able to partner with nonprofits like the Y, and reimbursement for this diabetes prevention program was able to improve outcomes and reduce progression of the disease. So really, it's also looking at other conditions where there are health disparities and there are issues and kind of replicating some of the work. And it's not a short fix. This is years. The diabetes prevention program was working for years to be able to demonstrate the community health worker model and reimbursement models for nonprofits, and to eventually be able to get Medicare service to reimburse for some of these models of care.
And I think it's worth mentioning also when we're talking about payers that Medicaid finances nearly 50% of all the births in this country. So they're by far the single largest payer of maternity care and also family planning services. So there, and as we've discussed, there are ways that state Medicaid programs can get creative with financing to support some of the innovative models that are out there, such as the North Carolina model, which is primarily through Medicaid. So I think there is innovation happening with payers, and Medicaid is the best example of it, given how much it does finance maternity care in this country. But I think there's still a continued need to push for better outcome measures to make sure that we are measuring improvements in care, and in particular measuring whether or not we're closing racial disparities when it comes to maternal outcomes.
So we have 17 seconds left, so sorry, no more time for questions. But please feel free to come and speak with the panelists afterwards. I think this has been a wonderful starting point and a continuing point. Thank you, everyone.